Good evening, my dear friends. Today we have one of the most important chapters in echocardiography. Although routinely we do echo day in and day out, the foremost important disease for which we do echocardiography is coronary disease. And for that, we have the star speaker from Indian Academy of Echocardiography, Professor Dr. Ravi Kasliwal, who is the adjunct professor of cardiology, National Board of Education. He is the chairman, clinical and preventive cardiology, program chair of DNB cardiology, Medanta, the Medicity. And he is the first president of Indian Academy of Echocardiography, and he is the president of South Asian Society of Atherosclerosis and Thrombosis. He has to his credit one book on echocardiography with the same caption, Echocardiography in Coronary Disease. So I now request Professor Dr. Ravi Kasliwal to give his address.
Thank you, Dr. Amuthan, for that very nice introduction. It's my privilege truly this evening to be speaking on the role of echocardiography in coronary artery disease. As you very rightly said, this is one of the commonest conditions for which we use echocardiography. And so let me start by saying that, let me get the first slide. What are the benefits of echocardiography? You know, if you look at it, one of the things which, when I was a student at the a senior resident at the All India Institute of Medical Sciences, when the first echo machine came there, one of the things that we realized immediately was the portability of the equipment available in virtually any clinical setting, immediate availability of results, and the fact that it was non-invasive, relatively inexpensive technique, and has none of the harmful effects of ionizing radiation. So these are some of the strengths of echocardiography. But very importantly, as the technique evolved to the current time, there is real-time assessment of cardiac morphology and real-time assessment of hemodynamics. That's what we want in coronary artery disease. And that's what we will talk about. So the role of echo in clinical decision-making, that it helps establish the diagnosis and severity of the disease. It helps you plan the management strategy. And very importantly, it plans and it helps you prognosticate the patient. If you know the ejection fraction, if you know the E/A ratios, if you know the LV/EDP, if you know the wall motion score, obviously you have a lot of things in your hands by which you can do clinical decision making. So the first thing, diagnosis of CAD, you have to go to the American Society of Echo model, wall motion and wall thickening. See, these are two important things. It's not just the motion, it's also the thickening. So hyperkinetic, if there is thickening, is more than 50%. But we are talking of normokinesia, hypokinesia, akinesia, dyskinesia, and aneurysmal today when we talk in terms of what is happening in coronary artery disease. Normokinesia, wall motion type, and thickening 30 to 50%, and this shows a normal perfusion and function. Hypokinesia, when the thickening and wall motion is less than 30%, ischemic or non-transmural infarct is what it will show you. Akinetic, no thickening, transmural infarct, or stunned or hibernating myocardium. Very important that the patient may have akinesia. Doesn't mean that it is infarcted or fibrous. It may just be a transmural infarct, or it may be stunned or hibernating. That means it may have chances of recovery. Dyskinesia, it bulges outwards paradoxically. Then you are quite sure it is infarcted and fibrosed. And of course, if it is aneurysmal, then it is thin and bulges forward. So you can imagine, if your patient has a high score, then more and more segments are involved, more. So this is almost, people use this Latin phrase, sin qua non, and please excuse me, there should be an E after the sin. Sin qua non of CAD is regional wall motion abnormality. So meaning thereby that without which you will not be able to diagnose CAD. Anyway, we do know there are many situations in which there may, but one of the important things which we all as people who use echocardiography commonly have to be able to predict and tell very, very clearly. Regional wall motion abnormality. It's not just about motion, it's also about thickening. So this was the patient, and you can see the wall motions very clearly here. In the mid-distal, in the distal septum, apex, and mid-lateral wall. Similarly, in the second view, you can see very clearly the apical wall and the distal septum. And this is what we found. On an angiography, the D1, D2 had taken off, and the LAD shows a 90% occlusion in the mid-LAD occlusion. The wall motions were already there. And here is another example. And if you can see here, the complete septum is hypokinetic except the basal part, the apex is but see, the wall motion, the wall thickness is maintained. And here you find a lesion which is just at the very proximal end of the LAD. Similarly, you have a patient here in which you will see that the complete posterior wall and apex are akinetic, and you know the RCA was involved. Now, site of coronary occlusion, well, I always tell my residents that, don't be too much hooked onto it, that which artery is which, but just picking up wall motion defects will be able to tell us that the patient has coronary artery disease, and then we can take it further. This is a schema from my good friend, Dr. Roberto Lang, from the journal of from JACE 2015, in which he has said that, you can get RCA in this LAD light green, LCX pinkish, but there is an overlap. There is an overlap, and that we have to understand. The reason I showed you these examples was also to show that it is of course very important to look at wall motion abnormalities, and sometimes you can also tell about which arteries may be most likely involved. So you see the 4-chamber view, the 2-chamber view, the long axis, apex, mid, and the base, and you will get a very good idea as to what you're dealing with. So synconon may not be a wrong. So let us start with the case. This gentleman was just 29 years old, smoker, no other risk factors, presented at 6 a.m. with persistent chest discomfort. And he said, he's been having it for the last 2 hours. And look at the ECG, except for a T inversion in lead V3 and lead 3, mostly the ECG looked quite normal. So the resident said, well, let's wait for a repeat ECG, let's wait for cardiac biomarkers. Of course, you can't thrombolize this patient because this is not a STEMI. And somebody said, perform a bedside echo. On the bedside echo, very clearly we show that the interior wall was hypokinetic, as also the apex and the distal septum. And lo and behold, when the patient was wheeled to the angiography lab, typical, he had a severe proximal LAD stenosis and thrombocyting distally, which is quite commonly, atherothrombosis is quite common in smokers. He obviously underwent a primary PCI to the LAD and recovered and has normal LVEF now. But see how much an echo can make a difference in the ER. And here I may just take 30 seconds off and say it's not about just picking up in the ER, it's not just picking up coronary artery disease, but it's also helping us from a disaster like thrombolizing a dissection of aorta, or giving aspirin to dissection of aorta, or looking at hypertrophic cardiomyopathy, or you may disclose a constrictive pericarditis. All these things can be diagnosed with an echo done in the emergency room. So that's where the value of echocardiography comes from. Emergency room to your ICU, to the cath lab, to the OR, to the outpatients. For CAD, it is echocardiography all the way. And the ECG later of this young gentleman showed ST segment, showed T-wave inversions in V2, V3, V5. Now, they can be regional wall motion abnormalities. We have just said 2 minutes ago that it is synconon of CAD, but sometimes you may have tardogenesis, you may have early relaxation, you may have left ventricular LBBB, ventricular pacing, ventricular pre-excitation, Takasabu syndrome, postoperative states, pericardial disease. All these things can also give rise to regional wall motion abnormalities. So when you have seen it, you'll have to put it in a proper perspective. So look at this. Look at this. This definitely shows the anterior septum hypokinetic or a wall motion abnormality. But no, this was the septal bounce as a result of left bundle branch block. So it is nice to know about the limitations of any technique. And of course, the strengths are with you. You know the strengths as we evolve, as we go along in this, we will know the strengths and the limitations. Now, when you look at RWMAs in absence of CAD, you will see that the overall thickening is usually preserved, as we saw in the last example of left bundle branch block. So here you go freeze frame, analyze frame by frame. It's only the sequence that is altered, and this just does not conform to any coronary vascular territories. So sometimes, it's important to know which territories are supplied by which, the wall motion abnormality that you have picked up is supplied by which coronary artery disease. And of course, here is an example. This does show some regional wall motion abnormalities, but this is non-ischemic dilated cardiomyopathy. So within a span of 8 minutes, we have said that, okay, you can have regional wall motion abnormalities, which is synchronous with CAD, but also keep your eyes open. It can be several other things. So expertise in picking up these things is very, very important. And so you can see here, normal function, as the patient comes to you with chest pain, what has he undergone? Normal function to start with, perfusion abnormality occurs earlier on. Then he has diastolic dysfunction, abnormalities of systolic strain, visible wall motion abnormalities, electrocardiographic changes, and chest pain. So it is important for us to realize what is the cascade and at what point we are seeing the patient. Sometimes the patient was living nearby, he may not show anything except the fact that he may have diastolic dysfunction. And as minutes pass by, you can get visible wall motion abnormalities. So it is something in which you have to know what you're looking for. Do not overdiagnose. Now, when you come to the outpatients evaluation of chest pain or people coming for regular sessions saying that, look, I had family history, my father died at age 55 or at an MI, I'm 30, please evaluate me. Then one of these things can be very helpful, that we can employ stress echocardiography. Everybody is aware of TMTs, but here we can do stress echocardiography, in which you can do treadmill exercise, bicycle ergometry, hand grip. And these induce wall motion abnormalities by provoking a regional mismatch between the blood supply and myocardial oxygen demand. So just as we talk about risk-benefit ratio, in stress echocardiography, in TMT, in thallium, we also talk about provoking a regional mismatch between how much blood can come. If the arteries were stenosed more than 65 or 70%, you increase the myocardial oxygen demand and you can unveil the presence of obstructive CAD. So 50 years old male came for a routine health checkup, diabetes, hypertension has been there. It's a classical story. A sedentary lifestyle person, BMI increased, and diabetic hypertensive. And as you see the exercise echocardiography, you already pick up some abnormalities. And these are, again, more so in the two-chamber position. And this patient could exercise only 7 minutes, about 5.5 minutes. Then we had to stop because of wall motion abnormalities and also chest pain. And this patient underwent CAG and had 90% proximal RCA stenosis. Mind you, I'm not speaking on just stress echocardiography, but I will say that STEC is reported as abnormal in the presence of wall thickening abnormality, but you should have at least 2 contiguous segments. And before you actually start a test, you must look at their pre-test probability. Here, of course, the patient was obese, the patient had hypertension and diabetes and came with chest discomfort, the chance of pretest probability of this patient of having coronary artery disease was very high. But if you have chest pain, changes two contiguous, more than two contiguous segments, you're pretty sure you're dealing with an abnormal. And this patient then underwent a coronary angiography and was found to have 90% proximal stenosis. So we are good at picking up. We are good at identifying. But are we also good at prognosticating? Yes, stress echocardiography is also good at prognostication, far better than a treadmill testing. Of course, we also employ treadmill testing here, but the prognostication comes because of the use of echocardiography, wall motion abnormality, and all the plethora of information that we can actually get from an echo. So if you look at Tom Warwick's work in Circulation 2001, and if you look at those who have normal response to a stress echocardiogram or have ischemia or have scar and ischemia, the average yearly mortality associated with a normal study was 1% per year for the first 6 years, with a small increase in events after 6 years. And this was not a small study. This was like 5,375 patients aged 54 plus minus 14 years, and a good mix of men and women. So it is not only about identifying, it is also about prognosticating. It's not about rushing patients to the cath lab, but it's telling the patients that, look, either you are safe or you're not safe, that you've achieved your target heart rate or 85% and above, but in that you have not been able to, you have not demonstrated any changes in this thing. So here is a study which I recently came across, patients with known CAD. This was Marquez et al. And they said, how does stress echocardiography help after percutaneous coronary intervention? And they said that patients with known CAD with negative results after a percutaneous intervention are at low risk for heart events in times to follow. But those patients who had inconclusive or positive results had significantly more events during cardiac event, during follow-up. So single center study, but it does give us a good idea that, see, not only can you define, not only can you diagnose, but you can also actually prognosticate and take the patients up for further investigations. This is a study from London, my friend Dr. Roxy Senior, and what he did was that he used simultaneously atherosclerotic and did stress echocardiography in patients with suspected stable angina with no history of cardiovascular disease, carotid atherosclerosis, and myocardial ischemia detected by ultrasound. He felt provided synergistic information in the long-term prediction of events. But atherosclerosis provided events beyond myocardial ischemia. So he gave a very provocative statement that, along with looking at the stress echocardiography, you can also do a quick scan of the carotid arteries, and they defined a plaque as a focal structure intruding into the arterial lumen equal to more than 0.5 millimeters or 15 millimeter thickness. So it does give you a good info that coronary artery disease, we don't have to wait for an acute coronary syndrome, or we don't have to wait for a coronary artery disease to develop, but sometimes we can be the guardians of the fact that they do not develop disease further, even though carotid intermedial thickness is not still in any of the leading guidelines, but it does open up a avenue in which it can be used. So this is from the United Kingdom, and I just mentioned this because it can be helpful in prognostication. Stress echocardiography, they can be false negatives as well. Many times people say, oh, this was an inconclusive stress. Then if it's an inconclusive stress, you can't say that it was negative. You'll have to say inadequate stress or an inconclusive test. And then you cannot prognosticate adequately with that. If the patient has been on beta blockers, sometimes the heart rate may not go up. Or if there's mild stenosis, less than 70%, sometimes LCX disease, or delayed imaging following stress, all these things are very important. If there is poor image quality, that also is extremely important, because if you haven't been able to image properly, then what you're doing is you're just relying on the TMT, and you know that the TMT has a very poor, has definitely less sensitivity and specificity like a stress echocardiography. Yep. So these are some of the false negatives. So when we train our DNBs and our residents in the art and science of stress echocardiography, we always stress the fact that you have to do a certain number under very close guidance, and only then can you be allowed to go free. So these are the false negatives. And of course, in the evaluation of coronary artery disease, stress echocardiography can also give you false positives, localized basal inferior wall abnormalities, or an overinterpretation or a hypertensive response to stress, or if there is an abnormal septal motion like a post-CABG status or LVBB, or it's a cardiomyopathy. So when you're evaluating for coronary artery disease, look at, just don't be focused on wall motions, which you are, of course, are important, but you'll have to look at many factors that can cause false positives and false negatives. So stress echocardiography, you can do exercise stress, as I've said, and you can also do Butamine stress echocardiography. Many people very commonly come for clearance for major non-cardiac surgeries, and a Butamine stress echocardiography is employed to rule out coronary artery disease, or some people who are unable to walk. Butamine stress echocardiography under the influence of Butamine is done, and very clearly, this is the resting, this is the 4-chamber position, this is the peak dose, and this is the recovery. And you can get huge information from this. For example, look at this. He developed wall motion abnormalities, very clearly seen in the 2-chamber position here. And the dilatation of the ventricle and the fall of ejection fraction is, of course, one of the very important points. So this gentleman then, although detection, so this gentleman then went for a angiography and was found to have significant disease. So although detection of myocardial ischemia is the primary objective of stress echocardiography or pharmacological stress testing, it provides plethora of other information that has significant prognostic and therapeutic implications. I dare say that in the imaging modalities now being coming up more and more in our spectrum, no other cardiac imaging modality can provide such an plethora of valuable information that stress echocardiography provides. And I'll show you that this gentleman was 65 years old, and he was posted for a prostatectomy. And since he had a CABG, obviously he had to have a stress examination before he went for it. So we did a DSC on this patient, and we found that he not only had wall motion abnormalities, but look at the fact that he also developed mitral regurgitation at peak exercise. So mitral regurgitation, diastolic disturbances, all these, or a restrictive inflow, all these things give us far more equally information about the hemodynamics that are taking place in this patient, in the particular patient. See this very, very clearly. You can see wall motion abnormalities, and of course, you can see mitral regurgitation at peak exercise in the 3-chamber position. So when you're looking at coronary artery disease and the multifarious ramifications in which it can come to you, echocardiography, correctly employed with knowledge base behind you, can be a great help to you. So this patient, because the patient showed wall motion abnormalities and also showed regurgitant lesion, the patient was taken up for CAG, and he had revascularization before he went for a major surgery requiring general anesthesia. So these are some of the things that you can do with clinical examination, a stress echocardiography, ECG, and help save your patients from the vagaries of this disease. So the overall accuracy, if you look at the number of studies the exercise echocardiography, the sensitivity 83%, the Butamine echo sensitivity 80%. So these are pretty good tests. In good hands, they can give a lot of information about where we are headed in such patients. As I was saying, that you can also get a lot of hemodynamic information, not only by doing stress echocardiography or a Butamine, but also you can get a lot of information on just echocardiography on a CAD patients. For example, restrictive diastolic filling predicts death after acute myocardial infarction. Systematic review and meta-analysis of 3,855 patients in 16 studies. It was found that 20% of patients had a restrictive filling pattern, and you can actually prognosticate these patients that at the end of 1 year, how many people actually didn't make it. Now, definitely this is an older study, and things have changed with immediate use of primary angioplasty, CABG, and lots of other things. But don't forget, you are getting immediate information on which way the patient should go. Some patients don't have to be, no time should be wasted, and they should go clearly ahead with further investigations. So you can get filling pressures. You can see here a restrictive inflow pattern. And this is a very, very useful information for as prognostication. And also here, look at the tissue Doppler imaging, and you can take tissue Doppler both in the septal and the mitral inflow pattern, and you can get a very good idea of the left ventricular and diastolic pressure. The patient may look fine after an angioplasty, which we have done, but the ventricle is not behaving properly. There is increased left ventricular and diastolic pressure. There is increased left atrial mean pressure. And these are the people who will go home and come back to you with left ventricular failures. You can also get a very good idea about the PA systolic pressures. You can see very clearly here, the PA pressure is over 35 millimeters of mercury, and obviously a inferior vena cava, which is full, you know that the RA pressure, the RA mean pressures are also elevated. So just look at the information that you can get by employing echocardiography on the bedside, but intelligently. Don't feel that, okay, a procedure has been done, and so what's going to happen? No, this patient is sitting on pulmonary edema. And of course, you will be able to pick up mitral regurgitation in many cases. So putting all this information, you have a complete picture of the patient as to what is going to happen, how will you treat them. And you know, in today's day and age, many of these patients who have acute decompensated heart failure, you do look at the ejection fractions, you do look at the PA pressures, and this may be a correct indication to start them on ARNI. From the paradigm HF study, you know that what a tremendous impact it can make. So I'm not saying that you can't do it without an echo, but then obviously without an echo, you wouldn't know where the EF is. Is it below 35? Is it below 50? Or if it is in between? These are important things. Heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, heart failure with recovered ejection. All this information can be given to you with the use of echocardiography in coronary artery disease patients. Also, many times patients have ventricular arrhythmias and the ejection fractions of the lower side. We do know that how EF taken over a period of time can help you with your electrophysiology colleague, that should you be actually giving this patient an ICD implantation. So all these decision making in coronary artery disease particularly, of course they can be used in cardiomyopathies as well, but in the context of coronary artery disease, where a bulk of our patients come from this, you can really make a big difference to this patient just by doing a good ejection fraction study, looking at PA pressures, looking at TR jets, looking at IVCs, and telling them and prognosticating these patients. So MI complications beyond LV systolic dysfunction. So obviously, one of the things that you will gain a lot from is just looking at the LV systolic function and diastolic function. But you can also look at MI complications. This is what Dr. Parashar always calls the dreaded MI complications. And here, again, your auscultatory skills and your brain telling you to do another echo this morning when you're hearing a murmur will save this patient. So let me tell you the difference between this is very commonly we see patient gets admitted with a TIA where he actually has a mural thrombus on a thinned out myocardial scar. This is a true aneurysm. This is true aneurysm versus a pseudoaneurysm. Prognostically, they are very, very different. So a true aneurysm has a wide base, walls composed of myocardium, and low risk of rupture, whereas a pseudoaneurysm, narrow base, walls composed of thrombus and pericardium, it is a high risk of rupture. Once you have seen this patient, that the wall is ruptured, nature has sewn a pericardium around him, this is the time to do a quick angiogram and ask the surgeon to do the rest. It's very important. 40-year-old male, ex-smoker, history of anterior wall MI 1 year ago, not thrombolized, presented to the ER with worsening dyspnea. And he, when I saw him, he just said, sir, I'm not just well. I cannot even get up. I'm breathless at rest. And just see what we found. Posterior wall, there was a pseudoaneurysm. This is the pericardium. And this is a patient in which I always tell my residents, look, if this guy gave a cough, he would have a problem. Because of this thin pericardium ruptures, then nothing can save him. So you can see the pouch here, and you can also see the thrombus setting here beautifully, and the blood flow going from the left ventricular cavity into the pseudoaneurysm pouch. So here is truly, when people talk of team heart, this is the best example of a team heart, that the cardiologist, the critical care cardiologist is sitting with the surgeon and saying, well, this is what it is, and you better get into action. Here, this is an aneurysm or a pseudoaneurysm. Obviously, this is a aneurysm here. You can see the dyskinesia and the thinned out apex, and this becomes a huge nidus for thrombi to set in. 55-year-old gentleman, smoker, no history of diabetes or hypertension, developed hemodynamically unstable VT, cardioverted, stabilized. ECG shows LAD and RCA lesions. And just look at this. There's a large abnormality at the apex. The question is it a large apical clot? Is it LV pseudoaneurysm? Is it LV non-compaction? Or is it an intramural hematoma? Here, obviously, because the Doppler is not passing through this at the apex here, most likely this is an intramural hematoma. It does not have any feature of LV non-compaction. It is definitely, there is no rupture of the LV walls, so it's not a LV pseudoaneurysm, but many times you may be fooled, but a color Doppler will make it clear. Also, don't go by just one, this patient of coronary disease, you will see a lot of wall motion abnormalities. Take several positions and then you will be able to see and look very clearly about intrahumeral hematoma. These are not so uncommon. You just have to think that they can be there. So this is a 53-year-old lady. She was hypertensive, diabetic, developed angina of effort 3 months back. Nobody took any cognizance of her. But then she presented with an infeval MI, and she had been thrombolized in a institution away from Medanta, developed sudden onset shortness of breath, and in the ER, on examination, she had a systolic murmur at the apex between S1 and S2, and just see it's not far away that this patient has got, on the first shot in the plaques view, you can see that the patient has a ruptured cardi. This is one of the conditions in which you have to act very fast. And in the This is a transesophageal echo. Very clearly you can see a ruptured chordae and mitral regurgitation, which is going up to the roof of the LA. No wonder here, all you have to do is to look, define the, and this is an off-axis view at 20%, at 20 degrees. All you have to do is to do a cath on this person and send them up for surgery. So papillary muscle rupture, if I may just take a minute, the incidence is approximately 1%. The time course, bimodal peak within 24 hours and 3 to 5 days, range 1 to 14 days. So you see, the patient is recovering very well in your intensive care, cardiac intensive care unit. And the next day, when you're telling people, oh, things are looking fine, they come back, they have developed a systolic murmur, and they have come down with cardiogenic shock almost. Clinical manifestations: adult, abrupt onset of shortness of breath, pulmonary edema, hypotension. What else can it be? And this is where, again, a team heart approach comes in, whether do you require an intra-aortic balloon pump, echocardiography you have done, and you have to rush to the cath lab. So physical findings: a soft murmur in some cases, no thrill, variable sign of RV volume overload, severe pulmonary edema, cardiogenic shock. Echocardiographic features are unbelievably correct. Hypocontractile LV, torn papillary muscle, chordae tendineae, flail leaflet, severe MR, severe mitral regurgitation on color Doppler echocardiography. So see, just by the use of echo color Doppler, you've been able to diagnose this patient and help them. So this also goes to show in what nuance a coronary artery disease can come to you. It is not just a blockage which you can open with or thrombolize. They can come in so many guises. And here is a classical example where echocardiography has been used from the ER to the ICU to the cath lab in one single day. 82-year-old lady, enteroseptal MI, STK, was given in another institution, had acute breathlessness on day 4. And just look at this. Now you can see at the apex here, you can see color Doppler, which goes onto the RV. I don't know whether you can see it clearly, but that's how we picked up a rupture. And here, now you can see very clearly that a color Doppler beam traversing the apex of the interventricular septum and going on to the RV. So don't be in a rush. These people will take time. This is a transesophageal picture because it was not so clear on transthoracic, but very clearly we could see, and therefore we also did a 3D echo on this patient, and we found very clearly a breach in the interventricular septum. This person's life would have gone, whatever you may have done, until and unless you patched it up with a device. And that's where I'm saying that you will require your own vision and good ECG and clinical features, and you will require a good echocardiogram to show you that this was a ventricular septal rupture. She gave you some time, but she wouldn't have given you another day. So the incidence is 1 to 3% without reperfusion therapy. The time course is bimodal again, just like the MR, within 24 hours and 3 to 5 days, range 1 to 14 days, and chest pain, shortness of breath. But these people also, like rupture, just collapse. But they have harsh holosystolic murmurs, thrill, accentuated second heart sounds, pulmonary edema, and RV and LV failures. And I've already shown you the echocardiographic features. It's a ventricular septal rupture, left to right shunt on color flow. Doppler echocardiography will also show you systolic flow through the interventricular septum and the pattern of RV overload. So this condition is quite common in elderly patients, females, those with CKD. So here, in a patient with coronary artery disease, you've been able to save the person's life. And here, I'm just showing a plethora of cases in which, in coronary artery disease with wall motion abnormalities, you can actually see thrombi. Some of these patients may not present to you. Some of these patients may actually present to the neurology service. And then when they ask for an echo, then you realize that they were actually harboring in the apex, a murmur, a thrombus. Myocardial viability, what is it? The term myocardial viability is used in context of dysfunctional myocardium in presence of CAD. Again, as Dr. Sanjeev, one of the pioneers on myocardial viability, says that, if the potential to live is viability. So it's traditionally defined as dysfunctional myocardium with reduced contractility, which improves after restoration of adequate coronary blood flow. Two subsets: viable non-ischemic myocardium, stunned myocardium. Second, viable ischemic myocardium, and this is hibernating myocardium. It's important to define. And what you have in your hands by echocardiography and low-dose butamine, you can find out what about the viable myocardium. So myocardial stunning, persistent contractile dysfunction with delayed recovery after transient ischemia despite adequate perfusion, and this can happen. Reperfusion can take place even over some weeks, and sometimes there is prolonged functional depression. So this was a term first used by Diamond in '78, and this was popularized by none other than Dr. Ravi, who did a lot of work not only on valvular heart disease but also on a hibernating myocardium. So chronic myocardial dysfunction, and can you find out that chronic myocardial dysfunction with the use of echocardiography? Yes, we can do that with the use of butamine echo. But first, as we said on the first slide, diastolic wall thickness, akinetic, old healed infarcts are often thinned out. Those are scars. But if there is reduced diastolic wall thickness, less than 6, but they maintain their thickness up to 6 millimeters, then they have a high positive value for viability, though the negative predictive value is very less. But if you see a person who is developing new wall motion abnormalities and also has in other segments reduced diastolic wall thickness, then you know that we are dealing with multivascular disease for this coronary disease patient. Myocardial viability can easily be found out, as I showed you some features of butamine echocardiography. Similarly, a low-dose butamine echo, 2.5 to 10 micrograms per kilogram per minute, will give you an idea whether these walls move, which you thought had diastolic wall abnormality. So you don't increase the heart rate to a great extent, but you decrease the afterload, and that makes them viable. So as you can see, normal myocardium will have this response to butamine echo, but a stunned myocardium and hibernating myocardium will not show any thickening in the resting stage, but will have, if it is a sustained improvement, it is stunned myocardium. If it is a biphasic response, this is the true ischemic response. Now you may well say, well, we don't use this, we use PET scan, whatever you may do, but there is a value in some patients of doing non-invasively by just having a look at low-dose butamine echo. And of course, if there is severe ischemia, then even this mild movement that you are seeing will worsen even at low dose. And of course, you can easily make out scars because at baseline level, low dose or peak value or peak dose, they will show no response at all, and easily you can pick up. So in the butamine response, you can see the sensitivity and specificity, biphasic response, biphasic worsening, any improvement, any change. So every lab will have their own number of patients whom they will just take them through low-dose butamine echo before they decide. And it's very common in diabetic vessels where the surgeon wants to know, look, should I vascularize them? They have multiple abnormalities, and here is something which can help you. And a low-dose butamine echo, LDDE, has a sensitivity of 84%, the specificity of 81%. Not so bad as compared to FDG PET or MEB. Here is an example. You can see very clearly that the wall motion abnormality becomes better in this segment at peak dose in the 4-chamber position. And you can also see this in the two-chamber position. Again, I may say that you have to be, or whoever is doing it for you needs to know very clearly between what is akinetic, what is dyskinetic, what is stunned. He has to have this in mind, and only then you will get the best results. So the impact on survival is controversial, but they say that if you revascularize patients who have who actually have got viability, a lot many will increase. But if you have viable myocardium and you give them medical therapy, thinking this was poor ventricle and they'll be high risk, then you're actually many of these people will not survive. Similarly, non-viable revascularization and medical therapy. Mind you, these are important things. You may say that, look, Bono's data on viability very clearly mentioned that, there's hardly any use of doing it. But then the 10-year data, which was published just in 2000, after just this year, they say that if you do CABG with viability, the prognosis is actually better. And you can see this here. And again, myocardial viability and mortality, you can see very clearly that those who had an intervention done after viability did better than those who had no viability, and they went ahead with it. And even though Bono's data in 2019 does not say much about viability, but definitely one of the slides definitely shows that those people who had viability and CABG definitely showed a better outcome. Whether increase in ejection fraction translates into more better life, that nobody knows, but there is data that if you look for viability, it can always help you in clinical decision making. Now, we have talked about regional wall motion abnormalities, but is the thing so simple? That there are challenges, and the challenges are in the visual analysis of regional wall motion abnormality. There can be subjective problems, interobserver variability, and there is a need for something more to come. And also, if you look at it, the subtle changes cannot be picked up, and we have seen that how strain is very valuable. So strain describes a change in shape of the myocardium, which results from deformation. So strain can actually give us far more information than ejection fraction. But see, here we are looking at segmental strain. We're not looking at global strain, as we look in aortic stenosis, for example, asymptomatic AS. So speckle tracking echocardiography, this is global longitudinal strain, and it gives us a good idea about the global longitudinal strain. Then you have circumferential strain, and then you have radius strain. But what you're looking for actually is segmental strain. That's very important, because segmental strain, and in this paper by Dr. Partha Sengupta in the Journal of the American Society of Echocardiography, I've read this article many times, and this is just an amazing piece of work. And what it tells you is that the blood supply in the subendocardial level is far more important. And that's what you need to pick up truly to actually define whether this patient has coronary disease before actually they even develop a wall motion abnormalities. But the only but that comes into this is that you have to have segmental strain, and this is being developed. But subendocardial will give you, subendocardial GLS will actually give you subendocardial flow, and this is where most of the things will occur. Once you are seeing through and through subepicardial and mid layers, then of course it's a transmural infarct, and your global longitude and your wall motion abnormalities will give you a decent answer. But this is technology on the horizon. Many centers may already be using it, but segmental strain will change this whole picture. So strain rate imaging will help us in detection of ischemia and diagnosis of acute coronary syndromes, transmurality of infarct, at the risk of ventricular arrhythmias, and that's what's going to happen. But what are the challenges? Everything is not hunky-dory. Whenever you look at it, a technique which is very, very good or something which you've used for years, just see. Sometimes there may be a suboptimal acoustic window. After all, a person who's sick you may not be able to position him clearly to actually get a good window. And then in many labs, in many hospitals, you may not get a good echo 24/7, but that's what the patient needs. And don't use the echo data in isolation. And of course, strain imaging in CAD is evolving and will be out soon. So be very clear. Sometimes you may have to use contrast to just define what is the optimal acoustic window. And there may be inability to position the patient in a correct way. So these are some of the things. So echocardiography is pivotal in the evaluation and management of CAD patients, regardless of their clinical presentation. Whatever they may come with breathlessness, they may have murmurs at the apex, they may be, you do need an echocardiogram. At every step, echocardiography provides a vast amount of information, which is both diagnostic and prognostic, that helps drive the key therapeutic decisions, whether it is medical management or catheter-based treatment or cardiac surgery. More so, now that catheter-based therapies have become so common, you will require this more and more. So with that, Dr. Amuthan, I say thank you to you and to all those who are listening to it. I have tried to cover several aspects and what I thought were the limitations. And I think the limitations can be taken care of once we have historically spent time with the patient. We have seen the ECG, we have seen the physical examination, done the physical examination, and then we have used echo to the fullest. Thank you very much, Dr. Amuthan, for chairing the session of mine. Thank you very much.
Thank you, sir, for your elaborative lecture on value of echocardiography in coronary artery disease. Unfortunately, there are no questions in the chat box, but there are a lot of points for discussion. Now, there are issues regarding the echocardiography in coronary artery disease, in acute myocardial infarction, and then in chronic coronary artery disease. First of all, we shall take acute coronary syndromes. Now, the guidelines don't suggest echocardiography as in the part of the examination of these patients. Do you agree with these guidelines? We see now more and more corporate and teaching institutions have handheld devices, and the residents are carrying these devices 24/7 to the emergency room. Do you see any advantage in treatment and management by using these handheld devices in the emergency room?
You know, Dr. Amuthan, I actually feel, and we have a CX in the emergency room, I think the sickest patient requires the best echo technician, the best echo person, and the best machine. The person who's waiting for a hypertrophic cardiomyopathy can wait, but these guys can't. They are, see, look at this 82-year-old lady who had this apical problem. Now, if you have not used the best equipment to pick these up, no handheld equipment can actually pick up these things. So I think I differ a little bit. That in the usual round of the patients, you can say, okay, it's better to see than to listen. But I think both listening and seeing is important. And guidelines are guidelines. Guidelines are good, but they're not guidelines. If we are dealing with patients who are below 40, below 30, 29 years old patients, whose lives have been saved only because there was somebody out there who looked at wall motion abnormality and said, look, don't worry about the biomarkers. And then you see what comes out. I'm not saying we should rush every patient to an invasive procedure, but at least as a clinician, as a critical care guy who's sitting in the ER, it behooves on us to do a complete echocardiogram, because we may be in for surprises. Some of these times, they may actually be patients of dissection of aorta and not even CAD. How will you detect it? So I'm not worried about guidelines. I'm worried about saving people's lives.
There is a question from Professor Shabash Kurishi. Does a wall motion abnormality occur before perfusion abnormalities?
Yes, generally these things will occur over a period of time. But the first thing is perfusion abnormality, and then quickly you will see diastolic abnormalities and wall motion abnormalities. This is just a cascade to little simplify the whole thing. But obviously, if the patient is having chest pain and at that time you do an echo, bedside echo in the ER, you're going to get a plethora of information. But your mind should know what you're looking at. That's important, that you're looking at diastolic abnormalities. You've done the tissue Doppler to look at increase in LVEDPs. All these things are important.
There is another question. What is the timing of echo post-acute STEMI, immediate or prior to discharge?
Yes, that's a very good question. We do it 24 hours after. We do it once before and once after the 24 hours when the patient is in the recovery room, definitely. And which means in a day or so he will go home. But before that, we want to know what's going on, because that also gives you an opportunity to modify his therapy. Would you like to give what kind of therapy you want to give him? What is his ejection fraction? You may think you opened the artery and put the best stent in the world, but his heart is not improving. So will he go in one day? Will he stay for a couple of days? Will he have Holter monitoring? What is his ejection fraction? All these are decisions you just can't take clinically. You will have to have something in your hands. That's what I feel.
Now there is another question. Post ischemia trial, they are more and more relying on imaging modalities to treat chronic stable angina, because post intervention and post optimal medical management, the optimal medical management appears to have a edge. Do you think echocardiography will be having a more definitive role in this chronic stable angina?
No, definitely. First of all, this word given by the Europeans, chronic coronary syndrome, is a good word actually. Otherwise, we were calling all these patients stable angina. But definitely, wall motion abnormality picking up will help us in guiding this therapy. See, many of these patients with chronic, those who continue to have angina, we do know that they don't do so well with just a simple aspirin, but they do so well with, as the Kappa study said, with rivaroxaban and aspirin. So somewhere down the line, an echocardiogram will definitely help. There's no doubt about it. By which I'm not saying that superfluously we should do an echo on everybody, but if they have a change in the pattern, if they have, or if they're not responding enough to medication, sure, go ahead, do an echo. You'll get some good information, or at least reassure the patient that nothing has changed. Either way, but that doesn't make the evaluation superfluous or meaning that one is wanting to do an echo at the drop of the hat. No, it just makes it more scientific.
How to differentiate LBB and MI on echo?
Yes, if you go by frame-to-frame analysis, and if you see that there is nothing else falling into place as far as the blockage of a coronary artery is concerned, then you will be able to make out very well. See, this thing always comes up when we are dealing with cardiomyopathy patients, that the LV is dilated and they have got an LBPP. And at that time, you can make out very clearly that most of the walls are moving in a hypokinetic way, but they are not according to a pattern of a coronary artery disease. So that's why I showed the first 3 slides. Of course, there is an overlap, but you will be able to make out.
What is the role of assessing the diastolic function routinely in coronary artery disease?
Yes. Assessing diastolic function is extremely important, because a patient has come out of a primary angioplasty, is ready to go home, but if the mitral EVA, a simple thing as a restrictive inflow pattern, shows that the LA pressure is elevated. And then if you have correlated it with a tissue Doppler, E by E prime more than 12, you are reasonably certain that in your therapy, you will have to include a small diuretic agent. And you have and call him in a week's time to see what is happening to that pattern. Because these people, when they have larger LAs, increased LVEDPs, they may be at higher risk of left ventricular failures, and some of them may be at higher risk of getting AFib. So LA strain and all these things will help us a lot. So diastolic parameters, I think, are equally important in an evaluation of coronary artery disease, whether you take it before procedure, during the procedure, or after the procedure.
Do you agree with the point that you must do routinely LA volume and LA strain in these patients post-procedure, or you do it routinely for all coronary heart disease patients?
We are doing LA volumes routinely for sure.
LA strain, reservoir strain, is it carrying an important note?
No, definitely. If required, you won't leave it. But as a person going home after a primary procedure, a good ejection fraction, E by A ratios, and LVEDP assessment is very, very important for a follow-up.
What do you suggest for a new resident who is entered the cardiology department when he is doing the echocardiography for the first time in a coronary artery disease patient? What are the things are expected of him?
You know, Dr. Amuthan, that's a question that he cannot make decisions of life just independently. In the first 6 months or 3 months, he will have to work under his senior to see what are wall motion. See, they look so simple. That's why I'm not at all, again, coming to your first question on handheld instruments. But it needs expertise. I mean, it needs expertise. Even if you leave alone a second-year DNB person in a stress echo lab, he should have independently done in his career at least 100, 150 stress echoes before he can take a decision. So that's why, as teachers of DNB programs, it behooves on us that we train them properly. So I would be very hesitant if this person came out and told me. I would definitely ask somebody to confirm all these things. And of course, the younger generation picks up very fast, so they'll learn. That's not a problem. And we are people who do with our own hands. I mean, we have text, but we do it ourselves. So that helps. The person knows that, yes, they're doing it.
Thank you, sir. There are no more questions. Would you like to sum up by saying some of the carry-home messages for our audience?
My most important carry-home message is that you have an important modality. It can be used at the bedside. It can be used repeatedly, recurrently. It has got no problem with radiation. Use it. Use it intelligently. Develop a system. If you're working in a hospital or a center, develop a situation where you can actually get an echo done at any point of time, in the day or night. That's very, very important. And don't overread or don't, if you have a problem, ask somebody that, look, this is what I think. But you may have saved hundreds of lives just by picking up ruptures and septal ruptures and mitral valve ruptures, or just assessing that here is a patient with such significant wall motions and the urine output is going down. This may be a situation to put an intra-aortic balloon pump. So you are in the midst. I mean, our surgeons call us so frequently to the recovery rooms after the CABG or other surgeries. So my take-home message is, this is an art and this is a science. It has developed beautifully. Take it forward, but be well aware of the nuance. Be well aware. It's not like putting a patient into a tunnel and then saying, oh, this is such and such thing. No, this is a modality which gives you hemodynamic information at your asking. That's why, see, we are able to pick up so many patients of heart failure with preserved ejection fraction, for example, where people said, no, 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 such entities don't exist. So it's just basically time consuming. Sit down with the patient, do a good echo, you save a life.
Thank you, sir. Thank you for excellent summing up of the carry home messages. I would suggest all our youngsters to take up this very important modality of echocardiography. Even though you are an interventional cardiologist or you are just entering the medical, specialty of cardiology, you have to start with the echocardiography and always treating a patient on drugs will require frequent echocardiographic follow-ups and assessment of both left ventricular systolic as well as diastolic function. So with this, we conclude and we thank Indian Academy of Echocardiography for having given us this chance to discuss this very important echocardiographic assessment in patients with coronary artery disease. I thank Dr. Parashar. I thank our president, past presidents, and secretary for this. Thank you very much. Thank you, sir.
Thank you, sir. Thank you very much.